coagulation factor. And the incidence of deep vein thrombosis ranged from 0% to 4.2% for a pool incidence of 1%. And in the right side, you can see the incidence of pulmonary embolism. We identified two studies with incidence that range from 0.8% to 2.4% for a pool incidence of 2%. In the landmark randomized control trials that assess the efficacy and safety of pharmacological thromboprophylaxis in hospitalized medical of VTE, in the intervention arm was quite similar, 5.6%, and twofold higher as compared to the PREVENT trial. And the reason is that in the MEDENOX and in the Artemis trial, investigators assess both symptomatic and asymptomatic venous thromboembolic events, while in the PREVENT trial, investigators only assess symptomatic VTE events during follow-up. And particularly for the PREVENT trial, the incidence of symptomatic venous thromboembolism was 2.8%, which was quite similar to the results that we obtained in the systematic review and meta-analysis. And these are the results in mission to the intensive care unit. We identify 5 studies with incidence that range from incidence of venous thromboembolism, in this case, deep vein thrombosis of 16%. And for the incidence of pulmonary embolism among ICU COVID-19 patients, we identify 7 studies with incidences that range from 3.3% to 23.1% for a pool incidence of pulmonary embolism in these critically ill COVID-19 patients of 12%. And again, these numbers are not very different to the numbers that we had in the randomized controlled trials that assess the efficacy and safety of pharmacological thromboprophylaxis in critically ill patients for randomized controlled trials. And you can see in this column that the incidence of venous thromboembolism in the intervention arm, meaning that these patients receive pharmacological 5% in the French trial. But I think that the bottom line is that if we want to know the true incidence of venous thromboembolism among COVID-19 patients who require hospital admission and who, in summary, and bleeding for patients with COVID-19 who require hospital admission. There are some ongoing randomized controlled trials that are comparing different thromboprophylaxis strategies from standard thromboprophylaxis to anticoagulation. And in my opinion, clinicians should have a very low P test threshold, particularly in those patients with COVID-19 patients admitted to the intensive care units who experience respiratory and
The thrombotic risk assessment in COVID-19 patients and the thromboprophylaxis. These are my disclosures, and you see that I'm trying to beat the clot with all the, let's say, partners. Abnormalities reported leading to venous thromboembolism, nuclear infection, and disseminated intravascular coagulation. Auditing the COVID-19 thrombotic risk, we must see the problem in 3 dimensions because it's related to the context, to the patient characteristics, and to the COVID-19 associated coronary artery thrombosis, which seems less frequent than venous thrombosis. Considering the patient dimension, we got here a well-known VTE risk factors such as age, renal impairment, obesity, previous VTE, immobilization, and that it's not new for thrombologists. And regarding the coagulopathy, we heard from David also that there is a huge increase of fibrinogen, D-dimers. They are disseminated intravascular coagulations reported. And there is also this pulmonary intravascular coagulopathy, which is particular. Regarding now various items belonging to 12 risk assessment models for patients, such immobilization, let's say obesity, severe acute infection, the, let's say, so it's not a surprise. But regarding now the accuracy and the discriminative power of these risk assessment models, they are not similar. You see that the improved 7-factor scoring got a very good negative predictive value and a better specificity compared to the other well-known Padua score. So the clinical judgment should supplement the RAS classification of hospitalized medical ill patients based on various clinical items. Proved which is more related to the vascular damage, to the occurrence of the PIC, the pulmonary intravascular coagulopathy, or the DIC. Is it more, let's say, related to any PE or DVT occurrence? Any failure of that antithrombotic strategy? But in fact, you see here that there is no clear cutoff and no, let's say, age-adjusted threshold defined and validated in this context. COVID-19 coagulopathy staging is already proposed, and it's based on, of course, the key organ, the lung, with a lung inflammation and adding also markers of COVID-19 associated hemostatic abnormalities with that depending on the stage and anticipation of the antithrombotic strategy may be proposed. But there are many other potential biomarkers as candidates for tailoring this strategy. So staging may be also used as a framework to consider interventions in clinical research setting. In fact, there is no consensual thromboprophylaxis in COVID-19. If all the experts agree to give prophylaxis at standard dose in all patients, irrespective to the RAMS result. In fact, you see that in some countries here, in case of obesity, they propose an increased dose for such thromboprophylaxis, whatever, in patients or ambulatory patients. Moreover, in ICU with a higher risk, you see that in fact, in let's say around 30%, they accept to increase the dose in case of additional risk factor, such as previous VTE, cancer, obesity, for example. But few countries and only 5% of the experts accept to give a curative dose, a curative regimen, based only on the biological marker, such an increase of the dimer, an increase of fibrinogen, and that it's not, of course, again, accepted attitude. In case of clinical probability of PE or DVT, again, only a minority of experts accept to give blindly a curative treatment without confirmation in this clinical suspicion. We learn from China that anticoagulant treatment reduced COVID-19 mortality, and the same message, 1/3 of the COVID-19 patients were receiving anticoagulation. And now, considering but in this population receiving anticoagulation, we observe a significant reduction of in-hospital mortality. And there is a more important bleeding impact, which is higher, 7.5%, higher than the 3% observed in non-severe and the global population. So longer anticoagulant treatment duration was associated with a reduced mortality risk in COVID-19 using such strategy. Is an extended prophylaxis needed in COVID-19? All of us know that at least 75% of hospital-related repeated assessment profiling is required to decide case by case if we may prolong this prevention in case of persisting risk factors in COVID-19 patients. So low molecular weight heparin is the first line drug for such prophylaxis because it's more dose adjusted regimen on body weight. It's very easy. There is no need for monitoring. However, some experts are requiring an anti-TNA monitoring in these frail patients, but there is no clear, again, target. In case of severe renal impairment, the unfractionated heparin is, of course, indicated, and again, with a repeated daily anti-TNA monitoring required. But again, for thromboprophylaxis, there is no well-defined and validated targets and values. And you know that low molecular heparin are pleiotropic molecules with many properties, with an anti-inflammatory impact, and recently reported a potential antiviral impact. What about DOACs? In fact, DOACs may be not so useful in these frail, acute, medically ill patients with so many co-medications, regarding limitations in case of liver or renal impairment, regarding the local bleeding risk, whatever GI tract or nasopharyngeal mucosal injuries in these patients requiring such numerous aspirations. So for COVID-19 thromboprophylaxis, many questions remain with no clear answers, and there is a need for action. We need more epidemiological data to define clearly the profile of the patients and the real VTE incidence in these patients. We need to define an optimized strategy, and there are at least 8 ongoing clinical trials trying to validate the increased regimen or not in these patients. What about the specific populations? Pregnancy, obese, cancer patients. Regarding arterial thrombosis, it seems also present in COVID-19 patients, but should we follow the same strategy? What about the bleeding risk assessment? There is no, let's say, real tool, and we are lacking of such, let's say, ramps in these patients, and the bleeding risk is not such high than the thrombotic risk, seems to be. Is the dimer the most pertinent marker for treatment intensification? Regarding the immunothrombosis and the microangiopathy reported in these COVID-19 patients, should we follow the same approach than for venous thromboembolism? So you see, another key problem is the education. Education is mandatory to increase awareness and to get a more regular implementation of guidelines. COVID-19 thromboprophylaxis is a difficult and a great challenge because COVID-19, for sure, it's an acquired major hypercoagulability with various stages linked to the polyfactorial prothrombotic process involving patient profile. Again, 3-dimensional approach and evaluation. And we have numerous protocols, different pathways, still no consensus, no validated, let's say, optimal strategy. Low molecular weight heparin is a first-line drug for COVID-19 patients in acute phase and in hospitalized patients. And maybe DOACs could be that delayed option to abolish such a coagulopathy in outpatients, but therefore we need to securize the drug-drug interactions, the, again, organ impairment, and to be sure that they receive the right dose for such thromboprophylaxis. So, thromboprophylaxis strategy. So, if you consider thrombosis and COVID-19, you must be aware, because that means thrombosis and context, comorbidities, co-craft, communications, contagion, And all these cofactors are important and must be taken into account to propose a better control, avoiding complications in COVID-19 patients. And this is my conclusion. Thank you for your attention.
Thank you, Ismail. So many questions, but you gave us a nice overview of the options and what has been done and what remains to be done as well. So thank you for that. And so we'll move to the last presentation, and we're delighted to have Professor Zhengguo Zai from Beijing, and he will discuss for us diagnosis and treatment of VTE in COVID patients. Zhengguo, floor is yours.
Thank you so much, Professor Legale, for your introduction. Today, I want to talk about the diagnosis and treatment of venous thromboembolism in COVID-19 patients. This is my disclosure. I have no disclaimer for the clinical interest. Today, I want to talk about the diagnosis and treatment. For the diagnosis, I want to talk about the clinical assessment and the utility of bedside ultrasound, and also the utility of CT pulmonary angiogram. In terms of treatment, I will talk about the use of heparin, especially the low molecular weight heparin, in the treatment of COVID-19 associated VTE, and the controversial point of the use of DOACs, and also the management of high risk of VTE patients in COVID-19. First, I want to talk about the incidence or prevalence of VTE in COVID-19 patients. Recently, there are some clinical studies already figured out DVT and PE is very common in COVID-19 patients. According to the most recent articles published in Annals of Internal Medicine, there's autopsy findings and venous thromboembolism in patients with COVID-19. In this study, the autopsy revealed deep venous thrombosis in 7 patients out of 12 patients in whom VTE was not suspected before death. And the pulmonary embolism was the direct cause of death in 4 patients. That means in the 12 patients of autopsy died due to COVID-19, there's a very high instance of DVT and PE in this kind of patient. And this is the autopsy findings of that. We could find very significant embolus in the pulmonary artery and also very big clot in the deep veins. This from 2 cases of the autopsy findings. And in our clinical practice, we also found some cases diagnosis as pneumonia at the very beginning. We could find some shadow in the lung window. At the very beginning, we think it might be due to COVID-19. But when we do some biomarker for the patient, we find the D-dimer level is very high. So the physicians there performed the CT pulmonary angiogram. They found that there's a lumen filling defect in the bilateral main pulmonary arteries and side branches. And the physician gave the patient low molecular weight heparin at the very beginning and during the hospitalization, and switched to rivaroxaban after discharge. When we repeat patient and follow up patient 3 months later, the patient recovered very well. So that means in the clinical practice, we do find some patient with COVID-19. If we find it earlier, we treat it earlier, the patient might have a good outcome. Why the VT risk will be found in the patient with COVID-19? All the physicians could know the 3 factors of a short trial. including the endothelial injury, the blood flow stasis, and also the hypercoagulability. During the progression of COVID-19, due to the inflammation, due to the infection, due to the staying in bed, and due to the dehydration, these factors can occur successively or simultaneously, and we also significantly increase the VTE risk. So this is a very common issue, and it's very necessary for us to find the patient with DVT and PE during the treatment of COVID-19. COVID-19 has fever, dyspnea, and some other symptoms due to the infection. But if we find symmetric pain, swelling, or discomfort presented in the unilateral or bilateral lower extremities, especially in some patients use central venous catheterization, if we find a local swelling or a superficial venous filling in the extremities of the catheterization site, we can think about the DVT occurrence. If a patient during the treatment of the fever, dyspnea, or some other symptoms, if the chest pain, hemoptysis, dyspnea, or hypoxemia occur during the process of the disease, which cannot be explained by underlying disease such as COVID-19, we should think of PE in this kind of patient. So regularly monitoring of COVID-19 is very important. If any corresponding symptoms of DVT and PE is reported, a physician should be vigilant for the occurrence of DVT or PE. And also, if we find a very sharp increase of the dimer, also maybe we think due to the inflammatory storm, but sometimes may be due to the occurrence of acute VTE. In case of the DVT or PE suspicion, the careful bedside clinical examination is very important for this kind of patient because of the infection and also the contamination. So in this time, we should think of using venous echo Doppler ultrasound or echocardiography for deep venous thrombosis or suspicious of right ventricular dysfunction. We can use the CT pulmonary angiogram for the diagnosis of pulmonary embolism if we have a very strict full protection measures for the patient. We can use it. And how about the strategies for suspected PE? In the patient with highly clinical suspected, if the clinical evidence of a lower extremity DVT or right heart thrombus was found, we can treat the patient as acute PE. If the patient has some unidentifiable or protection measures are adequate, we can perform CT pulmonary angiogram for the patient to confirm the diagnosis. If the condition of the patient is very severe, and also we cannot do some examinations such as CT or VQ scan due to the limited resource, the initiation of anticoagulation should be considered for this kind of patient if there's no contraindications. If there's a sudden aggravation with symptoms of high-risk PE, such as the low blood pressure and also cardiac arrest, we should think of the bedside echocardiography to rule out shock or cardiac arrest due to other reasons. If there's no other reasons, and if there's no contraindications, we can think of thrombolysis or other cardiopulmonary support for this kind of patient with the full informed consent from the patient and also their family members. So how to treat the patient, how to the treatment choice of this kind of patient. In COVID-19 patient, if we suspect patients with DVT or PE or relevant examinations, and if we cannot do something due to the restricted conditions, we can think about starting a curative anticoagulation with low molecular weight heparin as a first-line treatment. because the other drugs have some other side effect and also some other kind of drug-drug interactions. And in the critical ill COVID-19 cases, if there's some signs of mild or high-risk PE, such as hypertension, and also the patient have some hemodynamic deterioration or sudden cardiac arrest, if we find something, if we combine the circulatory collapse, and also if we could find a cardiac arrest, we couldn't find a reason. If we couldn't rule out the acute PE, we can think of using the ECMO. And the surgical epilectomy or catheter-directed treatment should also be considered if we suspect the patient with very high risk or if we confirm the diagnosis. So that is very important for the diagnosis and treatment of acute PE and DVT with COVID-19. It's very necessary for us to choose non-specific. So the Wells score and Geneva score and some other kind of clinical probability scores, difficult for us to use it in the clinical practice. How to use it, we could think about it. And how about unfractionated heparin in COVID-19 patient? At the very beginning, we talked about the low molecular weight heparin should be the first-line drug treatment for this patient. But if the patient have a very severe renal impairment, or the patient have some high risk of PE before the thrombolysis or after thrombolysis, we could consider to use the unfractionated heparin. And how about DOACs in COVID-19 patients? During the prophylaxis, especially in the hospital, it's very difficult for us to use DOACs. At the very beginning, some physicians use it, but during the treatment, we could find some side effect or some others. I think during the acute phase of COVID-19, we will use antiviral treatment or antibacterial treatment or some other complication. We should try to use so many drugs. The drug-drug interaction should think about when we use the DOACs. In my opinion, or according to our clinical practice, we suggest use the low molecular weight heparin during the hospital, but after discharge, if there's no other drug was used for the patient, we can use DOAC as a switch therapy for this kind of patient. And how about the D-dimer? D-dimer is a very interesting marker. Can we use the D-dimer to guide the clinical decision? Can we use the D-dimer to make a risk stratification? Can we guide treatment? And how to interpret the complexity with the D-dimer? I think D-dimer is non-specific, but it's very useful for clinical practice. I think we can use the D-dimer for the diagnosis and also the clinical decision. If the D-dimer level is normal, we can discharge the patient early. And sometimes if the patient is very mild, we can just ask the patient in out clinic. If the D-dimer level is mild or moderate increase, and we should try to do some VTE risk assessment for the patient. If the D-dimer level is very high, maybe we can suspect that the venous thromboembolism occurred, or maybe some other possibilities such as the inflammatory storm. And we can also use the D-dimer to guide the treatment for COVID-19, not only COVID-19, but also the COVID-19 related complications. If there's a mild elevation with clinical risk of VTE, we can think about the prophylaxis dosage of low molecular weight heparin and some other drugs. If there's a moderate elevation with clinical risk of VTE, we can think of some confirmed usage of diagnosis method. If we couldn't use the confirmed method, such as CT pulmonary angiogram, we can think about the treatment dosage of anticoagulation. And if the D-dimer level is very high, and also with the clinical deterioration, we should think of maybe a very high risk of PE or DVT, or a very severe deterioration of COVID-19. We can think about aggressive treatment, such as thrombolysis, such as ECMO, or some supportive therapy. So there's so many questions or so many issues we should think about to handle this question, handle the VT in COVID-19. VT in COVID-19 is a very common and a very critical problem, but this kind of condition could be handled, could be treated. If we find it early, we can save the patient. For the diagnosis, the clinical assessment is very important, and also the bedside method is even more important due to the contamination during the treatment of COVID-19. And in terms of treatment, we suggest the use of a low-molecular heparin as the first-line treatment, but other treatment could also be considered after discharge. And after evaluation, there's no drug-drug interactions. And also, I want to figure out here, there are so many unanswered questions of COVID-19 related venous thromboembolism, the dimer, and also besides the dimer, how about other markers, such as the PT, APT, platelet? There are so many questions that should be figured out during the treatment of COVID-19 associated VTE. So I want to see we still have a long way for the COVID-19 associated VTE and also for COVID-19 itself. But if we try our best, if we make so much effort, I think we will have a good future. And thank you so much for your attention. Thank you.
Thank you, Zengo. So that was a very practical presentation as well. So, well, thank you to all the speakers. And so we have some time, so which is great. So thank you for sending them our way. Perhaps I will start with David. And so there was perhaps two questions at the same time. When you did your systematic review, someone was asking whether patients in these studies were on thromboprophylaxis or not, and what do you think about potential influence on the risks in these studies? And kind of in line with that, someone was saying, well, there is a bit of discrepancy between what you were saying about COVID being a very high prothrombotic state, but at the same time you were saying perhaps the rates of VTE are not that much higher than what we would anticipate from patients with ARDS and from patients with acute medical conditions. So perhaps you can comment a bit more on that.
Yeah, thank you for the questions. Regarding our systematic review and meta-analysis, we pulled the data from all the studies that we identify, no matter the patients were receiving thromboprophylaxis or not, and no matter the patients were receiving standard dose thromboprophylaxis or intermediate dose thromboprophylaxis. But I can tell you that there was only one study, the quiz study, in which patients did not receive thromboprophylaxis at all. When we excluded this study from the systematic review and meta-analysis, we found that the incidence of deep vein thrombosis and pulmonary embolism among ICU COVID-19 patients were even lower. And I think there is not a real discrepancy between what I said, that a COVID-19 is a hypercoagulable state, and I reaffirm that. It is a hypercoagulable state. But my point is that I think that we don't have good data or strong evidence to say that COVID-19 significantly increases the risk of venous thromboembolism as compared to other septic processes. For instance, we still don't know if pneumococcal pneumonia is associated with a lower risk of venous thromboembolism as compared to COVID-19. So I think you can use both arguments. Number one, COVID-19 is a hypercoagulable state. Number two, I don't think that we have good data to say that the risk of venous thromboembolism among COVID-19 patients is much higher as compared to other patients with sepsis or with infectious disease. And if we don't have those data, it is very difficult to recommend standard management with intermediate dose thromboprophylaxis or even with full anticoagulation.
Hey, thank you. Perhaps for Ismail now. So there was one quick question about whether you should what's your idea on CRP, C-reactive protein in the risk assessment? And I'm sorry, I have many questions for you because there was perhaps again if Ismail you can go over the D-dimer thing again, and so there were some question about how often should we monitor them or what else was it there? Well, perhaps on these, more on the biomarkers first, summarize again what we know and what we don't know about D-dimer and that question about C-reactive protein.
Okay, so as you heard, that for sure, COVID-19 is a systemic storm with many, let's say, issues regarding inflammation, regarding coagulation, regarding, let's say, cellular injury. So we got many candidates to evaluate that consequences. And the problem is, in COVID-19, the levels we observe are terrific. And we got, let's say, D-dimers at more than 20,000, which is incredible. And CRP at 300, 400, which is quite elephant levels. So there are big surprises, but we must pay attention that the biomarker is not a thermometer for the fever, okay? There is no clear link between the clinical issue and the reality of the disease. Because again, what's important is to observe a decline of these markers. There are only, let's say, interesting markers for a dynamic evaluation of the patient evolution. Again, no one can today, let's say, establish a strategy just with one snapshot of the level of CRP or the level of the dimers and define the strategy based on a single evaluation. We must pay attention on the, let's say, kinetic of this marker. And again, in my opinion, the dimer increase observed in these patients is in relation with many causes. Because in this patient, and mainly in lung disease, we got a release of, let's say, improved fibrinolysis with the release of urokinase, and there is a fibrinolysis. And of course, the D-dimers are increased, but they are not only linked to the clotting, they are linked to the severe and to the cell damage. And in my opinion, the D-dimer is not, let's say, a marker of the prothrombotic, is a marker of prognosis, is a marker of damage, cellular damage. And for that, it's not so easy to define a strategy based on only biomarkers. So what we need now, we need to work together on a more, let's say, global evaluation of all these biomarkers, getting some data science and building some algorithm based on the dynamic evolution of this, and to create a real audit based on these biomarkers, but with the, let's say, an overlap between them, not a single one. Because again, one bird is not telling, let's say, the truth for the season or for the weather. So we must pay attention to that. Don't rely on one single biological marker. It's not the truth.
Okay, thank you. And then, so again, so Professor Zai, again, a lot of questions about your, your proposal on D-dimer as well. That drew certainly a lot of attention. There was also a question about, if you have a D-dimer test that's positive, but your CTPA is negative, you're happy with that, and you don't need to treat with full dose anticoagulation. Is that true? And there was another question about, a bit more on the role of the ultrasound with Doppler on the legs in patient with suspected PE. How can we use that?
You mean in the clinical practice, how to combine the D-dimer and the imaging technique when we diagnose and treat for the patient, right?
Yeah.
Professor Laguerre?
And if
Yeah.
you have a positive D-dimer, but the CT is negative, are we good?
Yeah. Yeah, that's true. In clinical practice, we often find that we find the D-dimer is very high, but when we perform the CT pulmonary angiogram, maybe it's negative. There's no positive result. But we couldn't rule out the deep venous thrombosis with the CT. Also, in some patients, the CTPA is negative, but if the CTPA couldn't diagnose the distal disease in pulmonary artery. So, in my opinion, if the D-dimer is very high, although the CTP is normal, we should think about to find another method to diagnose the patient. I will give the patient maybe prophylaxis dosage to prevent the DVT or PE in this kind of condition. But if we couldn't, if the patient didn't respond very well use the prophylaxis dosage, I will increase the dosage to the treatment dosage. So I think it's very difficult for us to answer this question. CT is only one method, but for the diagnosis of DVT and PE is very complex. We should combine the different kind of method to diagnose this kind of patient. So here I want to figure out, just as Professor Ilalami said, the D-dimer is a very non-specific biomarker, and the specificity not very high, but it's very useful. We couldn't find other markers such as CRP, such as some interleukin or TNF to guide the treatment, but I can use D-dimer to guide the treatment. So for me, I think if we couldn't use a method to make a final diagnosis of DVT and PE, but if the D-dimer is very high and there's no contraindications, I will give the patient prophylaxis dosage first. And if not, if the patient doesn't respond very well, I will switch to a treatment dosage. That's my opinion.
Good. Yeah, that's
yeah.
clear. Perhaps for David, because I know that's part of what you do, is one question about: do you think that hypoxia could also be a manifestation of subclinical PE?
That is a very interesting question, and I don't have a good answer for that. Meaning that we don't know if hypoxia related to COVID-19 goes first, or it is a consequence of pulmonary embolism itself. And for some patients, hypoxia might be reflecting just a diagnosis of acute symptomatic pulmonary embolism. But I would like to make a general comment regarding the management of these patients with COVID-19 related to venous thromboembolism. In my humble mind, I think that we are challenging many of the principles that we have been using for diagnosing venous thromboembolism and for treating patients with deep vein thrombosis and pulmonary embolism, just because this is a very serious disease. And I'm not sure if this is a good strategy. What I mean is that, at least for diagnosis, we know that there are some strategies that are very sensitive for the diagnosis of pulmonary embolism. And for the majority of patients, if we have a negative multi-detector CT scan, we have randomized control trial and management studies showing that this is a very good strategy to exclude the diagnosis of pulmonary embolism. And only for those patients with very high clinical probability of pulmonary embolism, for those patients, even with a negative CTPA, I may recommend performing ultrasound testing of the legs. And my second principle when diagnosing and treating these patients is that we know from many years ago that the higher dose of anticoagulation, the higher risk of bleeding, and that D-dimer is very unspecific, particularly in patients with COVID-19. So for this reason, I'm very cautious in clinical practice when recommended increasing the dose of anticoagulation or even using aggressive therapies such as thrombolytic therapy without, I will say, a strong confirmation of venous thromboembolism in these patients.
Okay, thank you. Thank you for the reminder. I concur with that for sure. Yeah. So Ismail, then a lot of questions obviously about thromboprophylaxis in general, and perhaps beyond what you've explained already, there are many questions about so, and as David was saying in his presentation as well, one of the issues that we lack good quality data on the actual incidence and on data to assess a risk-benefit balance, right? But still, we have to act. And so a lot of the questions are, do you think that some ambulatory patients with COVID should be on prophylaxis, diabetic, hypertensive, and they're at home, they're with COVID, do you think we should do something about it? And then a lot of question again about, I know you touched on that already, but on extended thromboprophylaxis, who would be the best candidates for that, or when would you suggest that we use that, which obviously are very difficult questions, not knowing exactly what.
Of course, it's obvious, as we said, and we know that COVID-19 is, let's say, the ensign, whatever in or out, let's say, patients. And we need, of course, to protect them. So it's mandatory. It's, in my opinion, mandatory to prophylax them. The discussion now is, should we increase that strategy to be more aggressive in some high, very high, extra high risk patients? And for that, we must get some information and scientific data from the, let's say, clinical trials ongoing. So for that, we must be anxious, but not too aggressive, and must wait again to define the in patients having already a risk factor for thrombosis, such thrombophilia, obesity, dehydration, immobilization. If you put on top of the inflammatory disease with, let's say, again, the cellular damage and again, a storm in these patients, of course, you must protect them and again, control this hypercoagulability with a well-defined thromboprophylaxis.
And perhaps since you have the microphone, some questions as well about any role for antiplatelet agents. We've seen also reports of arterial terms of thromboprophylaxis.
Again, the arterial wall and the venous wall are both, let's say, in such, let's say, incendiary situation. So if you are already requiring an antiplatelet activity in this war, and we are going to put on top of that an antithrombin inhibitor, which is more efficient with low molecular heparin than only the antiplatelet agent. So again, antiplatelet agent reduce the thrombin generation by 30% maximum. If you use a low molecular heparin, you are going to inhibit that thrombin generation by more than 80–90%. So for sure, in these high-risk vascular patients, the association of these two agents could be the better option. But again, the price to pay is an increase of bleeding risk that we accept during a short period of time to be more aggressive to protect them from thrombosis than letting them with an underdose of such prophylaxis and, let's say, keeping them only with antiplatelet agent, which is not enough to protect them.
And perhaps quickly, because I think you've answered that, but there was, questions again to clarify. So in your view, pretty much any patient with COVID admitted to hospital should be on thromboprophylaxis, right? I mean, because, usually we discuss a lot about risk assessment models, but I think what I understood from your talk is that COVID patients have many of these predictors anyway, and that most experts or most guideline documents are inclining towards a universal approach to, if you're not bleeding or if you don't have a high risk of bleeding, pretty much every COVID patient should be on thromboprophylaxis. Would you agree with that?
Totally agree. If you got a COVID-19, you must be covered by thromboprophylaxis, because it's again an ethical and let's say attitude and a mandatory attitude. And the other point regarding D-dimers, if I could add the comment, D-dimer means D-nightmare, because D-dimer is only a poor prognosis factor, making you anxious and, of course, asking for more intensive, let's say, action and treatment. But in fact, the reality of the clot, the reality of PE, the reality of, let's say, the need for a curative treatment, it's not at all proven.
Perhaps I will take one last question who just came up for Professor Zhai. Someone was saying, if a patient is on anticoagulants for another indication, say he has AFib or a mechanical valve, he's on anticoagulants, is he protected against the risk of suffering a VTE if he has a COVID infection? And I like the question because that's for sure a question that many patients ask these days. They call us saying, hey, I heard that COVID is a greater risk of clots. Is that okay if I just continue on my warfarin or on my anticoagulant?
Yeah, that's a very interesting topic. And in the frontline, physicians also always ask this question. If the patient is in normal condition without COVID-19, they can just continue using the drugs as warfarin of the NOACs, such as rivaroxaban. But if the patient during the treatment with valve disease or atrial fibrillation or VTE, but also combined with COVID-19, we suggest the patient should change the drug to low molecular heparin. The reason is that during the acute phase of COVID-19 or during the acute treatment of COVID-19, we should give the patient antiviral drugs or anticoagulation, antibiotic or some other medications. All the medications have some drug-drug interaction with warfarin or rivaroxaban. We suggest we should try to switch to low molecular with heparin first. And after the acute phase, if the patient recovered to a normal and then discharged to back home, we just give the patient back to rivaroxaban. That's the point. Yeah.
Very good. Thank you. Very clear answer. So I think it's time to wrap up. So I'm sorry about the many questions that we couldn't address. I let the pregnancy ones apart because that's a bit of a different topic in itself. I hope we managed to answer most of them. So perhaps just the speakers for their very clear and informative presentations. A few take home, I think I understood that it's a very complex, evolving, new data every day type of disease. We're certainly learning a lot. We can see that hypercoagulable state and the impact that it might have on the risk of VTE. As you've seen, we're not comfortable giving very strong advices on doses or management strategy because we still lack a lot of high quality data on risk of bleeding, on the incidence of VTEs. There were many questions about ambulatory patients, whether we should start them on PROF based on D-dimer levels and so on. We don't have any data on that yet. There were some questions as well, more about extended thromboprophylaxis. Again, we we need more data about what the exact risk of VTE in these patients when they go back home. Certainly, I've heard a lot of heterogeneity on the guidance document regarding thromboprophylaxis, but I also heard, certainly call for action in terms of we need to do it right, but also we need not to jump over what we know and what has been strongly established. And certainly the first step is to do what we know how to do right. And you've heard a very interesting debate about the role of the D-dimer, how could we use them, the fact that they are not certainly like the only markers that we should be using, but that they might help us monitoring these patients, and certainly as we always do, diagnose these patients. And perhaps as a conclusion or a summary, thromboprophylaxis strategies, certainly they need to be safe, simple, standardized for sure, and they need most of all to be implemented in these patients. So I thank you very much for your attention. I'm sure we again couldn't answer everything, but I hope you got some answers and a better understanding on the issues related to COVID and VTE. And with that, I will remind you again to fill out the online survey, the questionnaire about that webinar. And I will end by thanking again all my speakers here today and the audience and the organizers. Thank you, everyone, and have a good rest of your morning, afternoon, or evening.
Thank you.
Bye. Thank you.